Hi everyone, welcome to this live stream of abdominal radiology cases. My name is Vikas Shah. I'm one of the editors of Radiopedia. So this session is part of the conference Radiopedia 2020, which is our first ever virtual conference that we're doing. And I'm going to go through 5 cases just now with you. Hopefully you've had a chance to look at some of them, but if not, don't worry. I'm going to go through all the findings, talk about the signs, how to formulate the differential diagnosis, and then making the diagnosis. And if you're watching and you're thinking the first couple of cases are a bit too simple for you, then just please hold on because they do get a little bit trickier as we go on. Now, what I'm also going to do is a Q&A session just after I've looked at all of the cases, and I've already got some questions that have been pre-submitted that I'm going to answer. But if you've got any more questions, then please enter them into the chat box in YouTube right now. Let's have a look. I can see that some people have already put some comments in. So any comments you have about what I'm showing, any questions you have, and then I'll come back and look at those in a little while. And while I'm here, just to let you know that this is free to watch for anyone in the world, but this is part of the conference. There's loads of great content as part of this conference. So why don't you head on over afterwards to the Radiopedia website, and you will see a link there for the Radiopedia 2020 conference. We've had loads of positive feedback already. There's a lot of videos, I think over 60 videos available to watch. If you register, they're available for watching on demand for 14 days after the end of the conference. You've got plenty of time. There are English subtitles on all the videos. There are loads of brand new MCQs to accompany the talks that have been written just for the conference. And also check your access. Remember that this conference was free for people in 125 low and middle income countries. So go and check it out. Okay, let's get started with the cases. So the first case that we've got is a female with right lower quadrant pain. Now, not much more history apart from that. That's all we've got. So let's have a look at this. So we have a CT of the abdomen and pelvis with intravenous contrast, and it's been taken in the portal venous phase. So how do I know that? Well, because the density of the organs, such as the liver and the spleen here, is greater than I would expect for a non-contrast study. And I can see that there is high density in both the arteries, so the aorta, and the portal venous system. So that tells me this is a portal venous phase CT. And that's the standard kind of workhorse protocol that we use for most acute abdominal imaging. And as we scroll through, the upper abdominal viscera all look normal. Now, I normally teach my trainees that just don't be too misled by the clinical history and make sure that you look all around the abdominal cavity. But in this particular case, the right lower quadrant, where they told us the pain is really where the abnormality is. So let's have a look. And the abnormality is all centered on this structure here, which is the appendix. So what we can see here is the appendix is thickened, so the wall is of greater thickness than we'd normally expect. The wall has a greater density than we'd expect. Now, some people say this is hyper-enhancing. Now, strictly speaking, that's it's difficult to say that because enhancement after contrast implies that the density has increased from a pre-contrast study. And in most cases, we don't have a pre-contrast study when we do this type of CT. So strictly speaking, we can't say it's hyper-enhancing, we can say it's hyper-dense. However, almost certainly it will be hyper-enhancing. The density will have gone up after contrast. And then one other sign to look for is the fat has an increased attenuation. Now, this is a really important and helpful sign on abdominal CT. So look at this fat here. This is normal intra-abdominal fat. This shade of fat, this darkness is what we're supposed to look for. When that goes towards a whiter shade of grey, as it has here surrounding the appendix, then that's what we call fat stranding, and that's increased attenuation of fat. That's a very helpful sign of inflammation. And we can see that tracking circumferentially around the appendix. And as we go towards the tip, we can see that there is a very dense structure within the lumen of the appendix, and that's an appendicolith. And we often see these in cases of appendicitis. There isn't any significant volume of free fluid surrounding the appendix. There is some in the pelvis here, so in the most dependent part of the abdominal cavity in the pouch of Douglas, there's some fluid, but there isn't much around here. And another important negative here is that there is no collection or abscess, and there is no sign of perforation. So what do I mean by signs of perforation? Well, there's no free gas, so there's no pneumoperitoneum. And importantly, I can delineate the wall of the appendix throughout its length, meaning that there are no focal areas of gangrenous necrosis. And one of the themes I'm going to point out to you today is make use of the multiplanar reformats. So the coronal images here are really helpful because you can see in that one plane the appendix passing inframedially from the cecum down towards the dome of the bladder. We can see all those signs, the mural thickening, the hyperenhancement, and the periappendiceal fat stranding. So this is a case of acute appendicitis, but with no complicating perforation or abscess formation. And remember to look out for that appendicolith within the lumen. Okay, so let's move to case 2. Now, case 2 was a 50-year-old man with left lower quadrant pain and tenderness. That's the history we've been given. And this time we've got a CT again in the portal venous phase of the abdomen and pelvis. We've only got the axial series to work through. So as we scroll down, once again, aside from a cyst within the liver, the upper abdominal viscera look unremarkable. But then we spot there's an abnormality when we get to about the mid-abdomen. And the thing that should alert you that there's a problem somewhere is seeing this. So these are small bubbles of free air within the abdominal cavity. So there is a pneumoperitoneum in this patient. So our job is to figure out, well, where is this coming from? We've scrolled through the upper abdomen and the stomach and duodenum look normal. So it's not going to be from a perforated gastric or duodenal ulcer. And as we scroll down, it becomes apparent that the abnormalities within the left lower quadrant, once again, actually where they've indicated to us clinically the problem is. So there are a few things here. So first of all, the sigmoid colon, which is this loop of bowel lying here, is thick-walled. The wall is of greater density than we'd expect. So again, we'd say it's hyperdense or hyperenhancing. And there are many diverticuli arising from the sigmoid. So these are these outpouchings that you see here. So that's a diverticulum just there, that pocket of gas, an outpouching arising from the bowel. And there's many here on the posterior surface of the sigmoid. But this one here is a particularly large diverticulum. And moreover, there is some gas escaping and tracking free from this into the adjacent sigmoid mesentery. So all of this adds up to sigmoid inflammation, and with the diverticular disease, I'd say this is sigmoid diverticulitis with a localized perforation. I mentioned about the fat stranding, so look at this once again. We can see that the fat here immediately surrounding this diverticulum is of increased density compared to, say, for example, the fat over here, over in the right side of the abdomen. So that's a really useful sign to localize where the inflammatory process is. Once again, whilst there is a small volume of free fluid, there is no collection or abscess. And other important negatives that you should mention in this type of case are, is there any sign of fistulation? So there is no fistulation to the skin in the left lower quadrant. There's no fistulation to the urinary bladder or to other loops of bowel. Is there any associated venous thrombosis? So inferior mesenteric venous thrombosis is a complication, and sometimes that can seed up to the portal venous system, but we can't see any evidence of venous thrombosis. So this is a case of acute diverticulitis of the sigmoid colon with perforation and localized inflammation. Okay, and now let's look at case number 3. So case 3 is a 55-year-old woman who presented with severe abdominal pain. Okay, so once again, it's a portal venous phase contrast enhanced CT of the abdomen and pelvis, and we've got 3 planes to look at. So what we see from the very top is that the stomach is very distended and filled with fluid and air. So there's an air fluid level within the stomach. As we come down, we see that that doesn't really extend into the duodenum, and actually the most of the duodenum and the proximal jejunum is collapsed. So that's a little bit unusual. And then as we scroll down a little bit more, we start to see some dilated small bowel loops here in the center of the abdomen and coming down towards the pelvis. But equally, there are also many collapsed loops of small bowel, particularly down here in the right lower quadrant and extending to the ileocecal junction. So we've got this unusual pattern of the stomach being very distended, but the duodenum and jejunum not being distended, and then some more bowel being distended in the center of the abdomen, but then the very end of the small bowel, the terminal ileum, is actually collapsed, and as is most of the large bowel. So here again, once again, the multiplanar reformats come in really helpful. So if we look at the coronal views, we can see that there's an abnormality here. So there is a loop of small bowel, which is like a C turned on its side, which is very, very distended. And in addition to the distension, there is inflammation in the associated mesentery. So there is free fluid in that mesentery. There's also some vascular congestion. And this is a closed loop small bowel obstruction. This segment of small bowel here, this C that's turned on its side, is a closed loop. And if you look over here, there are two very tight transition points, and this is known as the double beak sign, which is very helpful in cases of small bowel obstruction due to a closed loop configuration. So this bit of bowel that's coming in here comes in, and then this is the first transition point, and then we have the bowel within the loop, and then over here this is the exit from the closed loop, and this is the second transition point. And note how they're very close to each other, and that's often the case with closed loop bowel obstruction. You'll find the two transition points close to each other where the bowel is pinched, and then all the bowel in between will be very distended. So that's the double beak sign, and the configuration here is highly suggestive of an adhesional band pinching the loops there. And as is often the case, what you'll find is a variable amount of distension of the small bowel upstream from the loop. So the bowel that's coming into the loop will be variably distended. Here we see that there is some distension of this portion of the small bowel, but it doesn't extend all the way back to the jejunum, but the stomach is distended. Okay, so there's this incomplete obstruction of the proximal small bowel, but the loop itself is markedly distended. I'd be more concerned about ischemia developing within this type of bowel obstruction than other cases because of the very tight transition point and the mesenteric vascular compromise. The fluid oozing into the mesentery is a concerning sign of the health of this bowel. So this needs an urgent report and urgent intervention by the surgical team. So remember to use the multiplanar reformats to your advantage to be able to pick out cases such as this one. Now, this is, as I said, due to adhesions. The other main causes of closed loop bowel obstruction include volvulus or an internal hernia. In the case of a volvulus, also look for swelling of the mesentery and the associated mesenteric vessels as well. All right, so let's move to case number 4. Now, case 4 was a 65-year-old man who's had abdominal pain, recurrent episodes of pancreatitis, and the CT is being done to look for complications from these episodes. So you can see the theme here. We've got another CT abdomen pelvis with intravenous contrast taken in the portovenous phase, and we're looking for complications to do with the pancreas. Now, the first thing is they've said episodes of acute pancreatitis. So could this be another episode of acute pancreatitis that's causing this man to present? Well, the pancreas is abnormal, but not in the sense of what we see with acute pancreatitis. So compared to what we see, and the best thing for you to do is just go and see a whole bunch of CT scans, which you can go and look at on the Radiopedia website, where the pancreas is not abnormal, to get a real sense of what normal pancreas looks like. But compared to normal pancreas here, this gland is enlarged, it's swollen, and the normal cleft pattern that we see is lost. So we're not seeing as much cleft pattern and lobulation as you'd expect to see on the surface of the gland. The other thing that we're not seeing, which you would expect to see with acute pancreatitis, is peripancreatic fat stranding and fluid. So in normal acute pancreatitis, what happens is you see all this, the fat around the pancreas is swollen, edematous, and we see that tracking down into the retroperitoneum, so in the fascia that's in front of the kidneys, but we're not seeing that here. So the positive signs are swelling, loss of lobulation, loss of cleft pattern. Now, in the tail here, there is a very subtle halo of low attenuation that surrounds the pancreas. So all of these features add up to a diagnosis of autoimmune pancreatitis or IgG4 related pancreatitis. And this is an entity of which we know more and more over the last few years. So this is a chronic type of pancreatitis. The fat stranding that you get associated with this type of pancreatitis is much less than with acute pancreatitis. It's often subtle and only in the immediate vicinity of the pancreas. Often you see a low density halo surrounding the gland, and here we can see that just about near the tail, where we can see this low density halo around the gland. Now if you look at a contrast enhanced study on the pancreatic phase of imaging, which this isn't, this is a normal portovenous phase, on the pancreatic phase of imaging at about 40 seconds, areas which are involved by autoimmune pancreatitis are hypodense compared to the rest of the gland, whereas in tumors, which is the main differential when you have focal swelling, in tumors there's often hyper enhancement compared to the normal gland. And speaking about focal acute pancreatitis, when it's focal, often the segment that's involved is the head and the uncinate process. And because it becomes very mass-like and edematous, the differential does become pancreatic adenocarcinoma. And in fact, many diagnoses of autoimmune pancreatitis are made on histology once the gland's been resected, because it was thought that this was a carcinoma. So what would we actually see on pathology? So we see an infiltrate of periductal lymphocytes and plasma cells, and also this perivascular inflammation. So you get an obliterative phlebitis in the gland. And you see those this infiltration in other organs that are involved with IgG4 related disease. So the kidneys, the lungs, the salivary glands, and also the biliary system. And if you look closely here, we also have signs of IgG4 related cholangitis. So the bile duct here is thick-walled and it's hyperdense. Okay, so in the context of knowing that there's IgG4 related pancreatitis, this is consistent with additional IgG4 related cholangitis and biliary involvement as well. Now, why is it important to make the diagnosis? Well, so you can make it on imaging, which is suggestive. They can check the IgG4 levels in the blood, and then that will be confirmative. So it's often the radiologist that is the person to make the first suggestion of this diagnosis. And if that diagnosis is confirmed, then this is really very responsive to steroid therapy, both causing morphological changes back towards normal, but also functional changes in the patient in terms of hormone abnormalities and so forth. Okay, and so our fifth and final case. So this was a 50-year-old man who presented with left lower quadrant pain. So if we look through this patient's CT, I'm going to just scroll down first and just show you that I'm going to focus on the colon. So the right colon here, the cecum contains fecal matter but is otherwise normal. The wall isn't particularly thickened or abnormal in density. And the transverse colon running across the abdomen here also looks fine. But we have an abnormality of the colon that commences from the splenic flexure, so from the end of the transverse colon. And as we scroll down this left side, we see that this descending colon is markedly abnormal. So the features that we're seeing here are that it's thick-walled, that the wall is of reduced density compared to other inflammatory processes. The lumen is very narrowed, or we're not really seeing that much luminal content, and that the fat around the colon has an increased density. So once again, it's that really helpful sign of fat stranding that we're seeing. And we can follow that all the way down to the sigmoid but the rectum is spared. Okay, so we've got segmental colonic thickening, low density swelling of the wall with pericolic fat stranding. And although it's difficult to see here, sometimes we get a target-like pattern when you look at the wall, the bowel. So you see mucosal hyperdensity, the wall is then low density, and then there might be subtle hyperdensity of the outer lining, and that's a target-like pattern. And this is very typical of ischemic colitis. So the distribution is from the distal end of the transverse colon down to the sigmoid, and this is the border zone, a watershed territory between the superior mesenteric artery supply and territory and the inferior mesenteric artery supply. And so this happens in low flow states or when during periods of hypotension. And in most cases, when you look at the vessels themselves, like the SMA or the IMA, they actually look normal in appearance with no filling defects. And most of these patients present with sudden onset of symptoms, pain, sometimes passing fresh blood, which is a brand new symptom for them, and imaging will show this, and then most of them will recover, although in some cases this does leave long-standing colonic fibrosis. So that was one thing, and then the other thing is that there is a background abnormality in the kidneys in this patient. So did you spot that? So the kidneys here are both, let's go to the coronal views because they're very helpful. The kidneys here are normal in size if you measure them, but that there are many small, tiny cysts involving both kidneys and importantly, involving both the cortex and the medulla. There is no hydronephrosis, there's no perinephric fat stranding, there's no obstructing calculus. So multiple tiny microcysts involving cortex and medulla involving both kidneys. This is a typical finding of lithium nephropathy or lithium-induced renal disease. So lithium is a medication often prescribed, and in the long term can lead to glomerulosclerosis and chronic interstitial nephritis and cystic dilatation of the tubules in the kidneys, which leads to this pattern of findings where you see tiny cysts involving both the kidney, the cortex, and the medulla. So what's the differential here? Well, polycystic kidney disease, you'd often expect the kidneys to be larger than this. With medullary cystic disease, often what you see is that the cortex is thinned and the cysts are only in the cortex. Acquired cystic diseases, such as patients on dialysis, you'd expect less cysts than this, and the kidneys should be smaller in volume. So there's a very limited differential for this type of finding. Now, that's not all. There is one more very important thing, perhaps probably the most important for this patient in the long term, which is that in addition to all of those findings, that there is a ill-defined mass here in the posterior aspect of the upper pole of the left kidney. So we see that there's a bulge in the contour, there is an enhancing rim, and then there's this ill-defined soft tissue density here within the center. This is highly suspicious for a renal cell carcinoma, and this will need working up with as if this was a renal cell carcinoma once this acute colonic stuff has all settled. Okay, so that's all the cases. Let's have a look at some of these questions. I've got some that have been sent in already, so I'm going to start with one of those. So this first question came in from Jose Flores. Thank you for sending in that question. So how do you visualize ulcerative colitis or diverticulosis with X-ray, particularly in the emergency setting? So in the emergency setting, there are a couple of different signs you might see on an abdominal X-ray of ulcerative colitis. So if there is active colitis, then you may expect to see colonic wall thickening, which will manifest as thumbprinting on an abdominal X-ray, and that's when you have thickening of the wall and an undulating appearance to the colon wall, which we typically see in the transverse and descending colon, and that's a non-specific sign of colonic edema that you may expect you see. So it doesn't specifically tell you that it's ulcerative colitis. It could be any type of colitis. And in a patient known to have ulcerative colitis who's undergoing a flare, one of the things you'd be concerned about is toxic megacolon. So in that setting, abdominal X-ray will show progressive dilatation of a segment of the colon and perhaps pneumoperitoneum if it's perforated. And in the long term, when the colitis has burnt out, then a sign known as lead pipe colon is seen. This is when the colon loses its haustration pattern. So you see a long elongated tube with really no pattern in the colon wall to indicate haustral faults. With diverticulosis, I don't think it's possible to really see that on abdominal X-ray. You can't really see individual diverticuli unless you've got some sort of contrast within them. So when we used to do barium enemas, but otherwise it's not really possible to see that on abdominal radiograph. Okay, I'm going to swipe across to the chat now. So let's have a look at see what questions we can see. So there's a question about suspected, so from Cherry Pudding 2710, clinically suspected mesenteric ischemia. Our protocol is perform an arterial and portal venous phase. Is there much value in adding a pre-contrast? So protocols vary everywhere. There is some value in adding a pre-contrast study in that you're able to first of all, assess the change in density of segments of bowel wall, which can be helpful. But just thinking about pre-contrast, often there's a setting in which patients suspected of bowel ischemia can't have contrast for some reason or other. Maybe they're allergic, maybe there's no IV access available, or there might be this whole issue of contrast-related kidney disease. And doing a pre-contrast study in those patients is better than just saying, well, there's no point in doing a scan because there's no contrast. So I think that it is worth doing. And the sign that we'll be looking for is hyperdensity of the bowel wall on a non-contrast study. And that's an indicator that there is mural hematoma or hemorrhage, which is one of the events that happens in the ischemia cascade in the bowel wall. And if you want to know more about bowel ischemia imaging, then one of the talks you can watch as part of Radiopedia 2020. In fact, on one of today's talks, it's about bowel ischemia, where I explain the different types of bowel ischemia that you can see on CT, so arterial, venous, mixed, non-occlusive mesenteric ischemia, and the utility of the different phases of the contrast. Okay, let's have a look. There's a question, ischemic, so from Hassan, ischemic changes of the colon can be only determined without arterial phase. So most of the cases of ischemic colitis that I see are done on a standard portal venous CT of the abdomen and pelvis, because a patient's coming in with sometimes non-specific symptoms and signs, and we don't know what we're going to expect to see before we do the scan. So that's our workhorse protocol, and we see those findings. So I don't think you specifically need an arterial phase to look for ischemic colitis. Remember that most cases are border zone or watershed territory ischemia, so there's no acute arterial thrombosis that we can detect within the SMA or IMA, so there's no need for arterial phase study in most of those cases. Okay, so question about the diagnosis of appendicitis on CT and non-specific ultrasound findings from Alyssa Calderwood. So that's an interesting question and prompts a lot of debate from people, from surgeons and from radiologists. So we have a protocol which basically says that the preferential choice for particularly young female patients with right iliac fossa pain is ultrasound, because we're looking for ovarian problems as well as appendicitis. But in cases where ultrasound does not make a positive diagnosis, we then move to CT. And this move to CT has been driven by the need to bring down negative appendicectomy rates, and has been helped by having better access to CT and reduction in dose with CT, which means that actually by making a positive diagnosis on imaging before the patient goes to theatre, we can be sure that they have appendicitis and prevent an unnecessary laparoscopy. Okay, let's have a look a bit more, a few more questions. So there's a question from Iman about, I think this is the referring to the case that we looked at, the closed loop obstruction, why the stomach's dilated and the duodenum and jejunum not. So honestly, I don't know, but what I do know is that in cases of closed loop obstruction, you don't always get continuous dilatation of the limb or the segment of bowel coming into the closed loop. It can be variably distended. And often the thing that triggers the patient's presentation is the sudden basically the tightening of the noose, if you like, around the neck of the closed loop, and that's what leads to the pain and then the systemic features. Okay, let's have a look. Any more questions? I'll scroll down to the bottom and see if there's any more. Okay, so there's a question here from David Littles. Actually, one of the speakers on the course has recorded a fantastic talk about PET-CT for the general radiologist, so go and have a look at that if you haven't already. David's question is, oral prep for acute abdominal CT, what do you use? When I started radiology, we used positive oral contrast, but now hardly ever. We sometimes use water, but often give nothing. Okay, so this is actually one of the topics I've covered in one of my talks, acute post-op imaging as part of the conference. Excuse me. So for most acute abdominal CT, we use no oral preparation. It's just intravenous contrast. That can make the diagnosis. There are some very specific scenarios where we use oral contrast. And those are where we're looking for gut leaks. So in post-op cases, if patients had, for example, an esophagectomy and a gastric pull-up, we give oral contrast looking for leaks. In patients who've had other procedures such as Roux-en-Y, gastrectomy procedures, we do it in those scenarios. And when we're looking for enterocolic fistulas and we're trying to map the small bowel, we give oral contrast. So for most acute abdominal CT, we don't use any kind of luminal contrast at all. And then Mohammed Yusuf has asked the same question regarding contrast in acute abdomen. Do you give positive or neutral contrast? So like I said, we don't give water, mannitol, any contrast for most acute abdomens. There are some specific scenarios when we're looking for either gut leaks or gut to skin fistula that we give some contrast. Okay, so let's swipe across to a few more of the other questions that have been sent in. So Hani sent in this question. Please explain the different types of bariatric surgery and complications seen on CT. So this is, you give me an idea, Hani, because actually this might be a talk that I could record and put up on the site, because I don't think we've got one. But some of the common complications. So with gastric banding, we look at the orientation of the band to see whether or not the band is slipped, and that can cause people to have acute dysphagia and vomiting, and we assess that by looking at the angle of the band relative to the vertebral column, and that's known as the phi angle. With peptic ulceration, sometimes the band can erode, and if it erodes into the lumen of the stomach, then it can pass down into the small bowel and cause obstruction. And there's a couple of cases of that on the website. If you go and just search for gastric band, you'll see those. Sometimes the band can be overfilled and can be too tight, so patients will have too much weight loss and be vomiting. Or it might be there might not be enough tightening, and it might be that there's not enough weight loss. Gastric or sleeve gastrectomy is another popular procedure in which the stomach is divided along its length, and often in the early phase there might be a leak from the staple line, particularly at the top end of the staple line, and so we'd be looking for leak of oral contrast or an abscess in the left subphrenic space. Roux-en-Y gastrectomies, another procedure. Again, we're looking for leak of contrast from the anastomosis, so from the gastrojejunal anastomosis. Another one is intragastric balloons. Now, these are not done very much, but what can happen is the balloons can perforate, and if they do so, they can migrate into the small bowel and cause obstruction. And there's a couple of cases of that on the website as well. Ola Lekan has sent in this question: what is the normal diameter of the portal vein in order to diagnose portal hypertension? Now, our measurements in radiology are tricky because you either love them or hate them. And I think for measuring the portovein diameter on ultrasound, I don't think many people I work with do not do that. There's a figure quoted in literature of 12, 13 millimeters, but there are some more helpful signs actually. So looking at the Doppler waveform pattern of the portovein, so if you see flow reversal or a biphasic pattern, then that's an indicator of portal hypertension. You might see collateral vessel formation, splenomegaly, and ascites, and you might see flow within the recanalized paraumbilical vein. So I think those are all more helpful signs of portal hypertension. Okay, and a question here from Hasiba Kashab. So mesenteric lymph nodes, when to report or when to ignore? And this is another great topic which we need to explore at some stage. So increased mesenteric fat in lymph nodes. So having a so-called misty mesentery is a quite common finding. So I think some papers suggest up to 8% of abdominal CTs have got this increased attenuation of the small bowel mesentery. And I think you can ignore most of those. Now, mesenteric paniculitis is when you have lymph nodes in the small bowel mesentery with the increased fat attenuation. And the diagnostic criteria that I remember for this are that you might have the nodes seen in a cluster. So particularly when you look on the coronal views, there might be some displacement of the adjacent small bowel, but the small bowel and the spleen will be normal in appearance. There'll be a definite edge to where the where the mesentery is inflamed. So that's known as the pseudocapsule. So the increased attenuation comes to a stop. And if you look very closely around the individual lymph nodes and the vessels, there is a halo of clean fat around them. So those are all very helpful signs. And there's no change on serial imaging. Now you need to differentiate that from something like sclerosing mesenteritis, which Michael Hartung has recorded a couple of cases of that in his talk today as well. Where you have this ill-defined soft tissue at the root of the mesentery, sometimes with calcification, and the patients will more often be symptomatic from this. So that is something to be concerned about, whereas mesenteric paniculitis in the strictest sense, should not be a cause of concern. Okay, let's just go across and see if there's any more questions. Okay, so there's a question from Wafa Mahmood. In post-op cases like splenectomy, there is only dilatation of the small bowel without large bowel in the first 24 hours. Can this be due to adhesions, or is this a limited type of paralytic ileus? So I think after any abdominal surgery in the first 24 hours, it is far more common to have an adynamic or paralytic ileus than mechanical small bowel obstruction caused by, for example, adhesions. Abdominal radiography will show non-specific dilatation of the small or the large bowel or both. And really, there needs to be some correlation with the clinical features, so how the patient's behaving. And if after 2 or 3 days, after 24 to 48 hours, 72 hours, the patient's not settling, there's persistent vomiting distension, that's when we would do CT to look for signs of mechanical small bowel obstruction. Let's have a look. Okay, so there's a question, any association between lithium-induced nephropathy and ischemic colitis? So no, I think in that 5th case that I reviewed, I don't think there's a specific link. I think that the ischemic colitis was the cause of the presentation, because remember that that patient presented with left lower quadrant pain. The nephropathy, I think, was just an incidental finding that was happened to be picked up on the CT. And okay, and then I think I'm going to go to one more question. So this is from El Kasabi, who posted this on my Instagram. So in abdominal X-ray, is it correct to divide the abdomen into 4 quadrants for assessment? Now, I don't do that when I'm reporting abdominal X-rays. I don't specifically look at each quadrant. I look at the abdomen as whole, but I do have a system where I look for specific things, but in the whole of the image. And once again, one of my talks today is about an approach to abdominal X-rays. So go and have a look at that, where I go into detail. But very briefly, the system I used is AbdoX. So that's my acronym that I remember. So A is for air, looking for signs of pneumoperitoneum. B is for the bowel, thinking about bowel dilatation, bowel wall thickening. D is for densities and areas of calcification. O is to examine the organs and the soft tissues, and then finally X for artifacts, extraneous objects, pretty much everything else, all the foreign bodies. And if you use that kind of system and approach and apply it to the whole of the abdomen, then you don't really need to divide up the abdomen into 4 separate quadrants. Okay, so thank you very much for watching this live stream. Thank you very much for all the questions and fantastic comments. Please make sure you go and check out the conference webpage. So go to radiopedia.org and you'll see right there that there's a link to the conference webpage. We've had loads of positive feedback, so go and have a look. Remember, all the videos are available on demand for 14 days after the conference ends. There's English subtitles on all of them. There's loads of MCQs that have been written to accompany the talks. Check your access. Remember that access is free in 125 low and middle income countries. And remember, if you're on social media, please send us any feedback you have. Send them to at Radiopedia or me at Dr. Vikas Shah with the hashtag Radiopedia 2020. And also any comments you have on Instagram over to me. I'm at the X-Ray Doctor. And go and enjoy the rest of the conference. Bye.